we are going to discuss the perioperative concerns in a patient with cerebral venous sinus thrombosis and patient who is also on direct oral anticoagulant, that is Apixaban. I had an interesting case. A 35-year-old female presented with pain in abdomen since 2 days. She was diagnosed clinically and on USG as ruptured ectopic pregnancy. She was inadequate NBM, known case of hypertension, known case of chronic cerebral venous sinus thrombosis of left transverse sinus, and recently treated by DSA, digital subtraction angiography, with stenting done in the left transverse sinus just 20 days back. She was on tablet Ecosprin 75 milligrams OD, tablet Apixaban 2.5 milligrams BD, tablet acetazolamide 250 milligrams TDS. The last dose of Apixaban was just 18 hours ago and Ecosprin was 24 hours ago. Acetazolamide, the compliance was low because of metallic taste sensation. So this patient has a very significant past history. She had conceived via IVF conception, taken 6 cycles with all hormonal therapies. She underwent LSCS 6 months ago, delivered twins at 36 weeks. She is not breastfeeding right now. She was incidentally diagnosed to have accelerated hypertension at first ANC visit, that is 7th week of gestation in the previous pregnancy, and was evaluated further to rule out end organ damage. On fundoscopy, there was severe papilledema. However, she didn't have any headache or blurring of vision, not even momentarily. So to evaluate the cause and extent of papilledema, MRI brain was done, and which revealed thrombosis of transverse sigmoid sinus junction. For this, she was admitted to ICU for observation and to decide the further plan of management in that pregnancy. Special multidisciplinary team was made. She was given option to terminate the pregnancy and undergo neuro intervention or surgery. Since the patient under observation for 15 days was asymptomatic and this conception was a very precious conception, they discussed the risks versus benefits, and they went ahead with continuation of pregnancy. Cytoreduction was performed. She had conceived triplets, so one fetus was reduced, and LMWH prophylaxis was given throughout the pregnancy. At 36 weeks, elective LSCS was done under spinal, and because she was twins with GDM with preeclampsia superimposed on hypertension and chronic cerebral venous sinus thrombosis. Uneventful post-op and no thromboprophylaxis was continued in the postpartum period. So in the surgical history, this LSCS, then IVF procedures 4 years ago, DSA stenting was done just 20 days back, and she had a history of COVID-19. She was not admitted for that, and she was vaccinated for COVID. So after LSCS, that was in January 2025, LSCS was done. After 4 months of LSCS, patient had 3 episodes of syncope in 1 month duration with fall and minor head injury in the first syncope. There was loss of consciousness and hypotension. No history of convulsions, headache, neurodeficit, weakness of any extremities or change in speech. ECG, echo and Holter were normal. So since she was already diagnosed to be a case of cerebral venous sinus thrombosis, MRI and MR venogram were repeated. Same findings were found out. Chronic cerebral venous thrombosis with thinned out appearance of right transverse sinus sigmoid sinus junction. Then DSA was planned. They showed intracranial venous hypertension with dural sinus stenosis. The left was stenotic and right was hypoplastic. She underwent stenting to the left transverse sinus sigmoid sinus junction with good opening under monitored anesthesia care, and it was uneventful post-op. She was on tablet Ecosprin, Apixaban and acetazolamide. On the day of admission for ruptured ectopic, she was pale. Her BMI was 39. She was pale, afebrile, heart rate of 102 per minute regular, respiratory rate of 20 per minute, blood pressure was 120 by 78 mm of Hg in right arm supine position. However, she was monitoring her BP daily at home. Her BP used to always remain 140/90, 140/80. So probably this was hypotension. She was having tenderness in the abdomen and there was incisional hernia at the site of LSCS scar. Airway examination, she was short neck and thyroventral distance was less than 6 centimeters. So it was a difficult airway and the spine was normal. On investigations, hemoglobin was 10.3 gram% and electrolytes were normal. PT-INR was 1.24, APTT was 43 seconds, BT-CT were normal, D-dimer was 600 and fibrinogen was 340. ECG, echo and venous Doppler of both the legs was normal, and the diagnosis was confirmed on USG as right tubal ectopic pregnancy. So in this case, the challenges for anesthesiologists were patient was a known case of dural venous sinus thrombosis recently stented just 20 days back, known case of hypertension not on any treatment, on direct oral anticoagulant that is Apixaban, Ecosprin and acetazolamide. Last dose of Apixaban was only 18 hours ago, inadequate NPO, difficult airway and unavailability of neuro intervention under the same roof. So how we did this case? We involved neuroradiologist, neurophysician, hematologist, and a physician, and all of them advised to at least wait for 24 hours to pass after the last dose of Apixaban. Since the patient was hemodynamically stable and under our observation, we decided to wait for another 6 hours. Blood grouping cross matching was done. 2 Paxils and 6 FFP, 4 cryoprecipitate were arranged. 2 wide-bore IV cannulas inserted. IV fluid ringer lactate started at 80 ml per hour. Urinary output monitored by catheterization. And the risk was explained to the patient and family, including the need to shift to a higher center for any neuro intervention if required in an ambulance. High risk consent and consent for blood and blood product transfusion was taken. ICU bed and ventilator reserved. Waiting for another 6 hours also gave us adequate NPO time. The plan was to do an exploratory laparotomy and removal of tubal pregnancy with primary closure of incisional hernia defect if easily possible without a mesh. Anesthesia of choice, because the Apixaban time was just 24 hours, we did not go ahead with neuraxial blockade. The anesthesia of choice was GA with muscle paralysis with endotracheal intubation and controlled mechanical ventilation. So we gave nebulization with a steroid. Metoclopramide, pantoprazole and ondansetron was given. Patient was wheeled to the OR. All standard monitors attached. 2 wide-bore IV were in place and fluid was going. We took an arterial line. We did not put a central line. We put an arterial line. Heart rate was 100 to 110 per minute. Blood pressure was 150 by 82 when we took her inside. So I tried to insert a nasogastric tube. In the first attempt, it was successful. We drained the gastric contents. Then pre-medication with injection midazolam and fentanyl was given slowly. Preservative-free lignocaine 60 milligrams was given IV slowly. Anesthesia was induced with injection propofol 130 milligrams IV. Quick check ventilation done, and I was able to mask ventilate. I gave injection dexamethasone 150 milligrams. Under video laryngoscopy guidance, trachea was intubated with 7-number cuff tube with the help of a stylet, and we confirmed the tracheal placement with EtCO2 and vecuronium and fentanyl. Vecuronium 5 milligrams was given. For maintenance, oxygen air sevoflurane and intermittent vecuronium was used. To manage hypertensive episode, labetalol infusion was kept ready, and to manage hypotension, vasopressors and inotropes were also kept ready. Introp findings, the surgical access was done through the site of incisional hernia. 500 cc of haemoperitoneum fluid was drained plus clots. Right tubal ectopic pregnancy was found and right fallopian tube was removed. Left was unaffected. Drain inserted. Closure was done. Total blood loss was estimated to be around 1 liter. Hemodynamically, patient was stable. Heart rate came down to 90 per minute, settled to 70-80 per minute. VP was 120-80 after induction. It increased to 140-86 and it remained throughout surgery. Urine output was 200 ml. We transfused 1 Paxil, 6 FFPs, gave 1 ringer lactate intraop. For pain management, we gave 1 gram IV PCM and fentanyl. Residual neuromuscular blockade was reversed with injection Sugamadex 200 milligrams IV. Patient was well reversed, well extubated, and nasopharyngeal airway was inserted to prevent tongue fall for half an hour. Patient was awake, warm, comfortable, obeying commands with minimal pain. She was shifted to ICU for post-op observation. For post-op thromboprophylaxis, enoxaparin 0.6 milligram subcutaneous OD was started 12 hours post-op. Oxygen was continued via nasal prongs. Patient was shifted to her room on day 3 post-op, and LMWH was stopped and oral Ecosprin and Apixaban started from day 4. She was discharged on day 5. So coming to cerebral venous sinus thrombosis. What is cerebral venous sinus thrombosis? It occurs when a thrombus forms in the dural venous sinus, obstructing venous drainage and potentially causing intravenous hypertension, venous infarction, or hemorrhage. So this red color seen is the venous thrombosis. Venous thrombosis is usually red in color as contrast to arterial thrombus, which is yellow or white in color. So cerebral dural venous sinus is formed by the cerebral veins. They join to form the cerebral venous sinuses, and ultimately via the sigmoid sinus, the blood returns to the jugular vein. So as you can see in the image on the right side, inside the skull and in between the brain, there is dura, which has these dural venous sinuses. What are the risk factors for cerebral venous sinus thrombosis? Estrogen related, obesity, oral contraceptive pill use, pregnancy, puerperium, estrogen containing hormone replacement therapy, acquired thrombophilia, antibody syndrome, hyperhomocystinemia, genetic thrombophilia, protein C proteinase deficiency, factor V Leiden mutation. Other provoking triggers are COVID-19 infection and vaccine-induced thrombocytopenia. So why do we need to discuss this? Because although it is a rare disease, but it is a catastrophic disease with an estimated annual incidence of 3 to 4 cases per million. Peripartum and postpartum disease approximately occurs in 12 per 1 lakh population. Women are 3 times more commonly affected than men, clearly because of the risk factors such as estrogen and pregnancy, etc. And younger females are more commonly affected. What are the clinical features of CVST? Most common symptom is headache, present in 90% cases, papilledema, visual disturbances, diplopia. Focal neurologic signs are motor weakness, hemiparesis, seizures. Involvement of straight sinus or severe venous thrombosis with hemorrhage can compress the diencephalon and brainstem, and in rare cases can cause coma and death. So the diagnosis is clinical, and we should have a high degree of suspicion for CVST. The International Study on Cerebral Vein and Dural Sinus Thrombosis categorizes it into acute, subacute, and chronic depending on the onset of symptoms. Less than 48 hours acute. Subacute is the symptom onset is 48 hours to 4 weeks. It is more than 4 weeks ago, then it's chronic. A subacute presentation is present in 60% cases, and the chronic is present in 7% cases. So our patient was a chronic case of CVST. So what is the pathophysiology? There are two mechanisms. First mechanism is because of the thrombosis of cerebral veins, there is increased venous and capillary pressure, decreased cerebral perfusion pressure, decreased cerebral perfusion because of the increased venous pressure. There is ischemia leading to cytotoxic edema, disruption of blood-brain barrier, interstitial fluid accumulation, and it can lead to intracranial hemorrhage. The other mechanism is because of the obstruction of venous sinuses, the CSF absorption is decreased, which increases the intracranial pressure. There is cytotoxic and vasogenic edema. Again, it can lead to parenchymal hemorrhage. So how do you diagnose this clinically? It can easily mimic a stroke, an arterial stroke, or a vasculitis. So any CNS disorder, any lesion of the brain can mimic CVST, whether it is benign intracranial hypertension or pituitary apoplexy, preeclampsia. Wherever there is intracranial hypertension, all those diseases can mimic cerebral venous sinus thrombosis. For clinical diagnosis, there is a score which includes seizure, known high risk factors like thrombophilia or OCP use, symptom duration of more than 6 days, and a description as the worst headache ever, and a focal neurologic deficit, and D-dimer of more than 500 micrograms per liter. So all these clinical things plus neurological findings. On CT and CT venography, there are specific signs. However, MR venogram is the gold standard for diagnosis. On MRI, we can also find papilledema and other complications. So how to identify venous infarcts from arterial infarcts? Arterial infarcts are limited to a single vessel territory. However, venous infarcts, because of various types of drainage, will have more than one vessel territory which will be affected. The diagnosis and management requires a collaborative approach from interprofessional team, including neurologists, neurosurgeons, radiologists, hematologists, and all of them. So once we diagnose cerebral venous sinus thrombosis, what next? So management is divided into two parts. First is initial stabilization and then the definitive treatment. First, we identify and treat life-threatening complications like because of raised ICT, seizures, coma, admission to ICU if the disease is acute. For raised ICT, elevate the head of the patient, give osmotherapy, anticonvulsants if seizures are there, and if needed, decompressive craniotomy if needed, then go ahead with that. Definitive treatment for venous sinus thrombosis is anticoagulation to prevent further thrombosis, thromboembolism, or treat the existing thrombosis. Endovascular therapy is recommended for patients who have progressive clinical deterioration or who have failed standard therapy or have contraindications to it. So the American Heart Association, American Stroke Association, and European Stroke Organization guidelines recommend anticoagulation in the form of low molecular weight heparin followed by oral vitamin K antagonist for anticoagulants for 3 to 12 months for transient risk factors or an indefinite period for significant risk factors. The duration of parenteral anticoagulation with LMWH remains unspecified. However, in place of vitamin K antagonists like warfarin, we can also use direct oral anticoagulants. There are many randomized control trials which have proven that direct oral anticoagulants like Apixaban are also equally effective in preventing recurrence. And moreover, the incidence of hemorrhagic complications is less with the direct oral anticoagulants. So after discontinuation of oral anticoagulation, antiplatelet therapy is to be decided on case-to-case basis. Prognosis of this disease, overall mortality is approximately 3%, which is very, very high, which is because of the complications related to hemorrhage. And a clinical scoring system such as cerebral venous thrombosis deterioration code is there. Poor prognosis is indicated by involvement of posterior two-thirds of the superior sagittal sinus, the confluence, straight sinus, or deep venous system. There are parenteral anticoagulants and oral anticoagulants. The direct oral anticoagulants we are going to discuss today are oral factor 10A inhibitors, that is rivaroxaban, endoxaban, apixaban, oral thrombin inhibitors, that is dabigatran. Warfarin is also an oral anticoagulant, which is a vitamin K dependent anticoagulant, which we are not going to discuss. So direct acting oral anticoagulants are rivaroxaban, apixaban, and endoxaban, and dabigatran. So what are the indications for the use of direct oral anticoagulants? Latest guidelines suggest venous thromboembolism prophylaxis, venous thromboembolism treatment, which is divided into initiation phase and maintenance phase, non-valvular atrial fibrillation, or stable atherosclerotic vascular disease. So Apixaban. Apixaban is a factor 10A inhibitor. The bioavailability is 50%. It is 87% protein bound. The half-life, very important, the half-life is 8 to 13 hours. And no monitoring is required in routine use of Apixaban. In case of emergency, to see the residual anticoagulant effect, we can do anti-factor 10A assay. And indications we just discussed. In patients, dose adjustment is required if the extremes of age, extremes of body weight, renal impairment, drug interactions of Apixaban. Apixaban is metabolized by CYP3A4 in the liver and forms metabolites, and they are renally excreted by binding to P-glycoprotein. So what the drugs which inhibit CYP3A4 or which inhibit PGP will increase the risk of bleeding because the serum concentration will increase. The drugs which are enzyme inhibitors will increase the concentration. The enzyme inducers like carbamazepine, rifampicin, phenytoin, or phenobarbital, all these drugs will decrease the serum concentration of Apixaban, will increase the metabolism and excretion, and thus increase the risk of clotting. So again, Apixaban dosing. So previously we used to write therapeutic and prophylactic dose. The current and latest guidelines use the term low dose and high dose. So Apixaban, a low dose is indicated for prevention of DVT and PE following PHR or TKR. The dose is 2.5 milligrams BD, and high prophylactic dose is indicated. In high prophylactic dose, 5 mg BD is used, and extremes of body weight, renal disease, and extremes of age, we have to decrease the dose to 2.5 milligrams. Therapeutic dose is 10 milligrams BD for 7 days, followed by 5 milligrams BD, the initiation and maintenance phase. And we have to strictly monitor and see for drug-drug interactions, especially in patients in which we are giving 10 milligrams, because the dose has to be reduced by 50% if the enzyme inhibitors are used. So now if we have a patient who is bleeding and is on direct oral anticoagulant, how do we go about it? So initiate standard resuscitation procedures as required. Take blood for full blood count, creatinine, blood group, antibody screen, routine coagulation studies for dabigatran, APTT, and thrombin time, and for rivaroxaban, prothrombin time, and rivaroxaban specific anti-10A level. For Apixaban specific anti-10A level, and ascertain the time of last dose. So first thing we do is stop further direct oral anticoagulants. Then classify if the patient has mild bleeding, clinically significant bleeding, or life-threatening bleeding. If the patient is mild bleeding, local hemostatic measures, and you can delay the next dose or discontinue by discussing with the physician. If the patient has significant bleeding and the last dose of the drug was less than 2 hours prior, we can give oral charcoal and it can neutralize the drug. Then local hemostatic measures, consider surgical or radiological intervention to identify and treat the bleeding source. So our patient fell in this category. She was clinically stable with significant bleeding, and the duration was, however, more than 18 hours. Considering the hemoglobin and the platelet counts, we can transfuse platelets and packed cells. If the patient is life-threatening bleeding who is on a direct oral anticoagulant, institute measures as in clinically significant bleeding, drug-specific reversal if it is available. For dabigatran, idarucizumab 5 milligrams IV. For factor Xa inhibitors, adenexate alpha or 4-factor prothrombin complex concentrate is to be used. In life-threatening bleeding or emergency surgeries, immediate reversal of antithrombotic effect may be indicated. In relevant residual DOAC concentration are expected and surgery cannot be postponed, we can give a 4-factor prothrombin complex concentrate in place of the specific antidote. So how do we monitor the oral anticoagulant drug? We have to do the anti-factor Xa activity or plasma level of the drug. So there are LMWH calibrated chromogenic anti-factor Xa assays which can be used to find out the residual activity of anti-factor Xa. Drug-specific calibrations are available. For dabigatran, we can use thrombin time. It is highly sensitive to dabigatran. And the plasma levels of the drug should be less than 30 nanograms per ml for each drug. We do not need to measure the residual anticoagulant level in every situation. Where we have to measure major bleeding, urgent surgery, new or deteriorating renal impairment, extremes of body weight, recurrence of thromboembolism, even after therapy, using concomitant medications like inhibitors or inducers, before instituting thrombolysis for treatment of acute ischemic stroke or other indications for thrombolysis. Coming to anesthesia. Neuraxial anesthesia, latest ASTRA guidelines suggest time to stop before insertion, like neuraxial blockade, to an interval of 72 hours to be taken for high dose of Apixaban, and for low dose, 36 hours is also enough. For rivaroxaban, 24 hours for low dose and 72 hours for high dose. Our patient was 24 hours had passed after his last dose of Apixaban, so clearly it was a contraindication for neuraxial blockade. For dabigatran, for low dose dabigatran, time to stop before insertion is 48 hours, and for high dose it is 72 hours. So for all oral anticoagulants, if it is a high dose, we have to wait for 72 hours, that is 3 days, and for low dose it is either 24 hours or 36 hours. Reversal of direct oral anticoagulant, there is a specific antidote available, which is a recombinant protein, adenexate alpha. It is approved for reversal of anti-factor Xa inhibitors like Apixaban and rivaroxaban if there is a life-threatening or uncontrolled bleeding. However, just prior to emergency surgery or for placement of neuraxial anesthesia, it is not approved because there is a risk of arterial and venous thromboemboli, ischemic events including myocardial infarction and ischemic stroke, cardiac arrest, and sudden death. So the present available data suggests against the use of idarucizumab, that is a dabigatran antagonist, and adenexate alpha, that is an reversal agent for rivaroxaban and Apixaban. Even for prothrombin concentrate complex or activated prothrombin complex concentrates to reverse activity of anticoagulant, this is a new recommendation. So once the surgery is done, when to restart? If the direct oral anticoagulant was used for a therapeutic anticoagulation, we have to wait for 48 to 72 hours in high-risk bleeding. If, however, it was a prophylactic dose, it can be resumed after 12 to 24 hours. In our case, Apixaban 2.5 mg was used, which is a prophylactic dose, so it could have been started after 12 to 24 hours. However, we had shifted on LMWH and started only after 3 days. Thank you.